Hi and welcome to Physiotutors podcast episode 48 with Jack March. Jack is a physiotherapist specializing in rheumatology who provides CPD courses on the recognition, investigation and management of rheumatological conditions. In this episode, we will talk about different rheumatological conditions that can mask as musculoskeletal pain and how to recognize them. We will shine a light on imaging and medical tests for different conditions and cover differences between genders. At last, we will discuss how patients with rheumatism are best treated, talk about precautions during exercise, and how to positively influence their prognosis. So make sure to listen to the whole episode and enjoy. Hi Jack, very nice to have you.
Thanks for having me. It's a delight to be here on the sort of responding side of the microphone for once.
Okay, maybe to jump right in and to set the stage, could you please give us a short explanation of what rheumatism is?
Yeah, for sure. So rheumatology or rheumatism or rheumatics, various ways of saying it, covers a really broad spectrum of diseases. Most of them are inflammatory in nature, so they involve a disorder of the inflammatory system or the immune system. And what basically happens is instead of reacting against things that it should react against, the inflammatory system starts to react against healthy tissue. To sort of put it really simply. So you've got this disorder, and instead of reacting to an injury or a bacteria or a virus or something, it starts reacting against your healthy tissues. So as physios, we would see that mostly manifesting itself as affecting the musculoskeletal system, muscles, bones, joints. But a lot of them will affect multiple other systems as well. So the gastric system, eyes, lungs, skin, you name any system in the body, then rheumatology conditions start to affect it. So they can become quite complicated. As you mentioned in your introduction, they do mask really well. So they'll present as things like back pain or tendon pain, and that's where they become challenging and they get missed quite easily.
Mm-hmm. And there are more than 200 forms of rheumatic diseases, and I'm sometimes a little lost, to be honest. Which rheumatological diseases should we know as physios and be able to distinguish?
Yeah, so you are right. There is a lot. The good thing is some of them are extremely rare, so we're just not going to see them. You know, they've happened once, twice, 3 times per year in the world. They're just extremely rare. Other ones we don't need to worry about, like I mentioned, don't affect the musculoskeletal system, so they're just not going to turn up in physiotherapy clinics. So there's a big chunk of them. The most obvious ones that we're going to see are things like rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthritis, or previously known as ankylosing spondylitis. And then slightly less commonly, we'll see some of the connective tissue disorders like lupus, Sjogren's syndrome. And then we'll see things like osteoporosis as well. So they're the main ones. The less common ones, when they come into a physiotherapy clinic undiagnosed, for example, you'd probably just think it was rheumatoid arthritis or psoriatic arthritis, and then later down the line it might turn out to be something a bit rarer. So what I tend to do is say to people, you need to know these 4 or 5 diseases. That'll get you pretty close to everything. And if it's something weird, wonderful and rare, then as long as you know those ones, you'll do pretty well anyway. Okay,
and say a patient is walking into my clinic. Which are the typical conditions in which I have to think of rheumatic diseases as well? So if I'm thinking about tendinopathy, for example, or chronic low back pain, is there something else? And so my question is, in which complaints should I have a heightened sense of alarm?
Yeah, so I suppose pretty much any joint pain or tendon pain could be potentially a rheumatological disease, and we'll come on to speak about how you might differentiate that about a bit more easily. But really, your key ones, as you mentioned, are back pain, especially with buttock pain, multiple joint pains. So obviously, rather than just a knee or just an ankle, if they've got multiple joint pains across knees, ankles, feet, hands, etc., and the more joints the more likely. And then the tendon issues as well, as you mentioned. So things like Achilles tendon pain, lateral hip pain, tennis elbow, those kinds of conditions. And then you would increase your suspicion if more than of those occur together. So if you've got multiple joint pain and tendon pain, or if you've got back pain and tendon pain, then you would start to increase your suspicion of thinking something potentially rheumatological is going on rather than just an injury. And there are other things as well, duration, onset. If someone's fallen down the stairs, they might have pain in multiple joints, but that's probably not a rheumatology condition. They've just fallen down the stairs. So there are onset things as well that can help guide you, and we can come to talk about those a bit more detail as well.
Yeah, exactly. That would have been my next question. So, which questions should I or do I have to ask patients in order to screen for rheumatological disorders? I know it's a bit different per subcategory, but in general,
Sure.
Which questions do I need to ask?
Yeah, so from a sort of general point of view, what I tend to do is pretty much a normal musculoskeletal type exam. So as I've just mentioned, I would ask about the onset of symptoms and things that can trigger a rheumatology disease are things that you would expect. So injury or illness can trigger it. Anything that increases the inflammatory system, anything where they've had surgery or anything like that, where their inflammatory system's been a bit elevated, that can be a trigger. But that can be proceed the symptoms quite significantly. So 3-6 months even beforehand. So patients might not attribute it. But you'd obviously be looking for, in that case, causes that might be something else. So as I mentioned, falling down the stairs, or an injury on the sports field or whatever to justify the symptoms that the patient's getting. Other things, if you think about back pain, would be like change of occupation or change of hobbies or change of circumstance where they're either sitting more or doing more, and it might cause them some other type of mechanical type back pain. Once I've sort of talked about onset and the nature of the symptoms and how they come about, I then do very similar things to what I would normally do. So I start to ask about things like 24-hour pattern, how it responds to activity and rest, whether it responds to medication, what kind of things make it better and what kind of things make it worse. And then, as I mentioned, then go on to sort of ask about other systems of the body and whether they're affected. And that's where it becomes a bit more individual on which disease we're talking about. So, for example, rheumatoid arthritis doesn't really, in the early days, affect any other systems of the body, whereas something like psoriatic arthritis is going to have a hallmark of occurring with psoriasis, so it's affecting the skin, and then you also see things affecting the gut or the eyes. So you then start to talk about other systems, and so that's how I start to build my clinical picture, really, is start to ask those questions. And then as it depends on the answers to those questions, you would then build what I call an inflammatory picture of symptoms, and whether the symptoms fit to that inflammatory sort of picture or pattern. And then are the other systems affected as well? And then the more of these answers that come back positive, the more likely we are to think it's a rheumatology disorder.
Oh, okay. That's a perfect segue to the following question, which is how is a normal inflammation different from a systemic inflammation like in rheumatoid arthritis or in rheumatoid disorders?
Yeah, so if you think about, I often use the example of an ACL rupture because it tends to have a clear mechanism of onset, and we know quite well what happens within the knee when it happens. So if we think about an ACL tear, you have that injury on the sports field usually, you rupture that ACL and it starts to bleed into the joint. So a couple of things happen. You get the broken cells have chemicals in them, and also the blood gets into the joint. So those two components, what they do is they irritate the synovium of the joint, so the lining of the joint. And that creates a cascade of inflammation that basically brings in things that will start to heal that process. You don't want your ACL bleeding for the next 2 years, for example. You want to stop that pretty quickly. So things like platelets and white cells get into the joint. They stop that from happening. Once that acute reaction has finished, so it's not bleeding into the joint anymore, obviously you're not creating any more injury, hopefully, then what tends to happen is the inflammatory system settles down. So it's not being triggered again and again and again because you're not having an ACL rupture every day over an extended period of time. What happens in something like rheumatoid arthritis is essentially the same thing, but it's external to the joint. So what happens is your inflammatory system starts to react against the synovium from the outside. So there's no internal disruption to cause that, but the inflammatory system starts to react against your synovium. And the same sort of things happen. So you get white cells, you get platelets into the joint, but they've got nothing to heal or nothing to repair. So they just sit in the joint and cause problems, basically, because there's nothing there for them to do. Because there's no settling of that, there's no healing process to occur, that process doesn't settle. So it just keeps on going and going and going. So it would be the equivalent of having an ACL rupture day after day after day after day. And you just get this continuous inflammation. Things change biochemically over time, and it becomes sort of more of a chronic rather than an acute process. And your synovium becomes acutely active. So not only is your inflammatory system continuing to activate the synovial structure, but it also is sort of more easily activated as well. So you get this whole cascade of things that keep happening just to keep that inflammatory process going. So what I often say to people is, if you take a photograph of a knee, you can't tell if that's had an ACL rupture or if that's rheumatoid arthritis. You need that clinical information we've just talked about to try and get the answer to the question. And then you can start to bring in things like, I've had a twisting injury on the sports field. And you go, right, well, I think that's an ACL rupture. It's red, it's hot, it's swollen, feels unstable. That was 2 weeks ago. That's very different to, I had an ACL type injury 9 months ago and it's still red, hot, swollen. So you have to take a lot of this information in context and how it appears, because that inflammatory process, the effect on the joint is the same, but it's just driven by a different process, if that makes sense.
Okay, yeah, that totally makes sense. And if we look in concrete at signs and symptoms of rheum versus, for example, if we take a tendinopathy. Mm-hmm. So I know in your webinar you talked about morning stiffness as one thing. And there's also other signs like uveitis, or if you look at the eyes or fingers. Can you elaborate on that?
Yeah. So that would be sort of the inflammatory pattern of symptoms that I talked about. So that would be symptoms being worse first thing in the morning. That tends to last for at least 30 minutes, but can be extended out for hours. It tends to be better with activity and worse with rest. So if you think about a standard Achilles tendon problem, go for a run, it feels worse. These patients, the opposite's true. They go for a run, it actually feels better. And when they sit around, it feels much worse. They wake up in the night. They tend to wake in the second half of the night with symptoms. So around 2 or 3 a.m., they'll wake with those symptoms. And it tends to be better with anti-inflammatories, which is not surprising, being that it's an inflammatory problem. So you combine those things together, and theoretically 3 out of those 5 symptom profiles would be consistent with an inflammatory pattern of symptoms. And then coming to the second part, you're talking about sort of associated or comorbid diseases as well. So these are also disorders of the inflammatory system or the immune system, which are associated with types of arthritis. So uveitis is a really good example. So uveitis is an inflammatory condition of the eye. And in patients with uveitis, about 50% of them have a spondyloarthritis, so either psoriatic arthritis or ankylosing spondylitis, something similar. And these things are just really commonly associated. So about 80% of patients with a spondyloarthritis will develop uveitis at some point during their disease process as well. Similar conditions would be Crohn's disease or ulcerative colitis, so the gut and the bowel being affected by inflammation, and then the skin with psoriasis that we mentioned, and you mentioned about fingers, so you can see hallmark changes in the fingers. So there's in psoriasis you get changes to the nails, so they become thick and brittle and they break off easily, but you also can see things like dactylitis, which is sausage digit, so the entire digit will swell, so you get this sort of looks like a sausage. It's about 3 times the size of a regular digit. Mine's obviously the same size as normal, but it starts. What the real classic is, so it will start in the finger and then extend out. So classically, it spares the MCP rather than rheumatoid arthritis, which would be swelling of the MCP really, and you get this very swollen finger. So those are really common. So these are the sort of associated inflammatory diseases that go along. So if you go back to thinking about how we were building that inflammatory pattern, you would classically see something like someone attends your clinic with back pain. They've got a history of a Achilles tendon problem, and they've got a history of ulcerative colitis. And those three things added together makes it much more likely that you've got a spondyloarthritis. And then you include things like the inflammatory pattern of symptoms. So they seem like they're stiff in the morning, symptoms are worse in the morning, better with anti-inflammatories, and this picture builds of something that's sort of an inflammatory process.
Mm. And say if you have a suspicion, is there any medical imaging or medical tests that can help with the diagnosis?
So again, this gets back into the individual diseases. You've got to know the tests, and we'll be here all day if we go through them all in this. But if you, it's key to know which ones you need to order. So in some diseases, for example, if you do the blood tests for rheumatoid arthritis and the patient has ankylosing spondylitis, they'll all be negative. And the opposite is true as well. So if you do the bloods for ankylosing spondylitis, then they'll be negative in rheumatoid. So there are blood results, obviously, that you can do. And standardly, these would include inflammatory markers, ESR, CRP, and then some more specific tests. There are some genetic tests you can do. There are some specific antibody tests you can do. So you'd use that as some of the information. And then imaging, again, would depend on the symptoms that are presenting. So people with inflammatory back pain, you'd use an MRI, and there are specific sequences that you need on the MRI. And then you would, in rheumatoid arthritis, for example, probably use something like ultrasound to have a look at that synovitis of the joint. You can use things like X-rays to look for damage to the joint, but that's not going to be particularly accurate, especially in early disease. So tend to use X-rays much less. MRI and ultrasound probably the best options really on imaging.
And is there any difference between men and women when it comes to rheumatoid diseases? Yeah.
So so again, I keep saying this, it's a bit specific to which disease you're talking about. So something like rheumatoid arthritis, for example, women tend to have more joints affected, and it tends to be more of the smaller joints. Men tend to have less joints affected and the larger joints. So typically a lady would present with sort of multiple MCP joints affected, whereas a man would present typically with a wrist. But then both can present in the other way as well. And then if you look at the spondyloarthritis patients, men tend to present with a very classic picture. So they have very inflammatory back pain. It's very centered around the spine and the hips. And they'll typically have things like uveitis associated with it. Whereas women, they tend to have much more peripheral disease. So they will have back pain, but it'll be less inflammatory. And they'll also have sort of hand, foot, leg, generalized pain as well, and they tend to be a bit more associated with things like colitis and psoriasis. So there are some slight differences. The inflammatory picture is pretty much the same, so you're looking for the same sorts of things, and unless you're specifically involved in the diagnosis, you're probably going to be looking for the same sort of patterns, but it's just, especially in axial disease in women, it's making sure that we ask the right questions and make sure we're picking them up, because they do present just that little bit less sort of obviously, if that makes sense. And we just have to go looking for it a little bit more.
Yeah, I remember that in your webinar you mentioned that women often have spondyloarthritis without any or the non-radiographic spondyloarthritis, which was quite surprising to me. Like I didn't know that, and I can imagine that if you refer for X-rays and it doesn't show up on an X-ray, that you think it's something else.
Correct. Yeah. So,
do you think that's one reason why the diagnosis for rheum is made so late, especially in women?
Yeah, definitely. And X-rays are very easy to obtain, and they're very cheap. So it is something that a lot of people can, you go, oh, I'll x-ray that. But unfortunately, as you mentioned, there are multiple problems with that. So x-raying for axial spondyloarthritis for women is pointless. Very few of them will develop structural changes in the sacroiliac joint and the lumbar spine. And if they do, it tends to be a lot longer into the disease process. So it takes a lot longer. But it's important to remember their disease is not less than men's. They have the same burden of symptoms. They just don't, for some reason, just don't develop the structural damage. So, as you mentioned, you're just not going to see that on X-ray. And the same sort of things in the other diseases as well. If you X-ray the hands and the feet, it's much less likely to pick up those sort of the damage to the joints than something like ultrasound. It's going to do it much earlier. So yeah, you're totally right. If you think about the difference between an ankylosing spondylitis patient who comes in and they're male and someone does an X-ray, you're much more likely to see the damage. Get diagnosed. There you go. If you're a lady, they come in, they're less inflammatory and they're less likely to show on X-ray. So they diagnose them with something else. And unfortunately, yeah, the delay increases. So it is important to make sure that we're investigating properly. And one of the things that I advise people to do, especially as physiotherapists, unless it's your job, you're working in rheumatology or diagnostics or something, is to do the minimum amount of diagnostics that you can and refer into rheumatology. So whatever the smallest amount you can get away with, ideally none, but that's not always possible. But as little as you can do to get them into rheumatology and let them do it, because as I mentioned right at the beginning, you said these diseases mask as musculoskeletal problems. Some of the diseases mask as other rheumatology problems. So you think you're looking at, oh, that's definitely ankylosing spondylitis. And then you realize later it's not. It's something else masquerading. You've done all the wrong tests. And that's what rheumatologists are for. That's why we have rheumatologists, is so they can take apart those challenging cases. So it is difficult. If it wasn't difficult, we wouldn't have delays to diagnosis, and I probably wouldn't have a job, talking on podcasts and stuff. So it is difficult. It does require a lot of time and practice and seeing these patients to really get into it. So definitely refer out to rheumatology as able, really.
Okay, and say I have a patient with rheumatological disease and I refer them to a rheumatologist. How good is the medical management, and what does the medical management consist of?
Yeah, so it is pretty good these days. So when I started in rheumatology in about 2010, it was still not as good as it is now. So they have made great strides recently in the last few years. Most patients would go back to full function, not necessarily no symptoms, but they are looking at full function. So back to work, back to sports, back to hobbies, whatever they want to do. Usually they would use like a escalating series of medication mostly. So most patients would start off with something like anti-inflammatories, naproxen, ibuprofen, the COX-2 inhibitors like celecoxib, etoracoxib. And then you move on to what they call disease-modifying anti-rheumatic drugs, or DMARDs. And those things consist of things like methotrexate, sulfasalazine, hydroxychloroquine, really difficult stuff to say and spell. And what those do is, rather than the anti-inflammatories, which generally suppress your inflammatory system, reduce inflammation in general, these are a bit more targeted. So they affect specific parts of the inflammatory system. Some of them, for example, that there are proteins and white cells that cause the inflammatory system to be more active, so they might affect it there, or they might literally block some of the antibodies, for example, and those things will settle it down. And then if those still aren't working, then you go on to things called biologics, and they're engineered drugs which really go into specific parts of the inflammatory system, usually enzymes, and stop it from being so active, essentially. So you escalate through these cascades of things. And most patients, like I say, will get to a very good set of function from that.
Okay, and I suspect the earlier I can refer someone to rheumatology, the better.
Correct. Yeah, so pretty much the biggest the biggest predictor of poor outcome would be delay to diagnosis. So the longer someone waits, the worse their outcome is going to be, pretty much across any outcome you can think of. So early diagnosis is definitely key, and then starting on the correct medications. It's obviously important not to over-refer, so you don't want to refer every patient, but definitely really trying to work into getting the right patients to rheumatology as early as possible is definitely the way forwards.
And how long does it usually take till a patient is referred?
So how long does it take from physiotherapy to, on average, do you mean?
Yeah, I can remember that you mentioned something about how many years it takes till a patient with a rheumatological disease is usually diagnosed properly.
Oh, I see, yeah.
That was quite a high number.
Yeah, so rheumatoid arthritis, we're pretty good. That's average is about 6 to 9 months. But axial spondyloarthritis, it's about 8.5 years delay to diagnosis. So that's from symptom onset to diagnosis. And as you mentioned, men are a little bit less, so it's about 7.5 years, and women are a bit higher, so they're about 8.2 years they're waiting for diagnosis. And they, on average, will see 6 different clinicians in that time. So theoretically, 5 clinicians are missing that disease or misdiagnosing that disease on average. And those are averages. So some patients are diagnosed very quickly and some patients are diagnosed extremely slowly to average that out. And then you take something like lupus, a connective tissue disorder, and that can be anywhere between 11 and 15 years, depending on where you look as a delay. So yeah, horrendous. You know, if you took 11 to 15 years to diagnose things like diabetes or cancer or whatever, people would be extremely unhappy about it. So there are a lot of projects going to try and speed that up. Recognition, and you know, some of it's not all healthcare. You know, there's a lot of information saying back pain, for example, it's not anything we should be worried about most of the time. You don't need to do too much about it. You know, we see a lot of that kind of information. So patients don't attend the doctor or the physio, whatever. They just get on with it. And don't, you know, you're not going to get referred to rheumatology if you don't present to someone to refer you. So there are multiple reasons that that's happening, and trying to shorten all of those down is really important.
Yeah, I think the more reason to record a podcast with you.
Yeah,
to increase awareness.
Yeah, exactly. That's what I try and do.
rheumatology.
That's what I do. Yeah. So I try to do that, and hopefully I'm making some impact here.
Yeah, I'm sure you do. Okay, so someone is receiving medication. What is then the role for us as physiotherapists? Is there a role?
Yeah, absolutely. So what I usually preface this with things like, you know, as physios, we don't tend to impact on the disease process that much, but what we're really looking at is function. So if someone might have pain still, and then in which case, you know, how do they do their activities? How do they do their sports with or reducing that level of pain, but also returning them to function. So they might have reduced range of motion, reduced strength, reduced cardiovascular fitness, you know, those things that we're really quite good at. And so we can do that how you would normally do that. There's no special skill for rheumatology patients to do that compared to anything else. But also really important role in education. So general health, general activity levels, those things have been shown to be really beneficial in the outcomes for these patients. So the more activity they're able to do, and the healthier sort of lifestyle they go through, they tend to do far better. So lots of education around diet, exercise levels, staying at work, managing any symptoms that they do have, returning them to function, for example. That's where our skill sets really lie. So you might not be seeing them, you know, go back to the ACL rupture once they've had a surgery or into rehab or whatever. You see them quite regularly. You might not see these patients quite so regularly. You might see them maybe once a month, maybe even once every 2 months, to try and instill lifestyle change, depending on what they need. So it's slightly different, but the skills are roughly the same. And we do have that really strong role, and it's about understanding the individual, what they need to do, what their limitations are, much like we do with any condition, really.
Yeah, I was just about to say that it's not so different from any other diagnoses or pathologies that we cannot influence, but we can influence everything on an impairment level.
Exactly.
And say if I do a exercise treatment with a patient with rheumatoid arthritis, for example, are there any precautions, or is it different than exercising with someone with osteoarthritis, for example?
Yeah. So not really. There's really good research showing there's no detriment doing even high intensity or heavy lifting exercises with any of these types of patients, rheumatoid arthritis being a primary example. They can do whatever they want to do. What I tend to say is they might not want to because it hurts, or because that's just not what their style is. But you can pretty much do what they want to do or what you want to do with them from an exercise point of view. There are some slight changes to that if and when they have structural change. So in rheumatoid arthritis, for example, you get classic drifting of the MCPs. I can't make my fingers do it. So they'll drift due to a bit of instability at the MCPs, but also erosions. They'll cause that. So what will happen is they tend not to either be able to make full fists or grip properly. So you might have to adapt exercises. But again, none of the exercises are going to make that worse, particularly. So it's more of an adaptation to the exercise. Things with ankylosing spondylitis, for example, if they get spinal fusion, they're not going to be able to flex or move their spine as much as a person without ankylosing spondylitis. So you might have to adapt things like squats, deadlifts, exercises. They might not be able to stay in a static position for quite as long as someone else. You might need to do shorter amounts of different exercises. But again, it's just adapting to the individual. You wouldn't give necessarily a 12-year-old the same exercise as you give a 92-year-old. It's just a part of them that you're adapting slightly. But from the exercise point of view, you're fine. And there's no worries about doing heavy or high intensity stuff if that's what they want to do. Even sports, they're fine to go and do sports. If they want to play high contact rugby, for example, and they've got fused portions of their spine, that might not be the best idea. But if they've played rugby all their lives, then a bit of education and make sure that they're building into it's fine. I wouldn't start rugby, for the first time. Probably I'd shy away from that a little bit. But technically, we know of professional rugby players with rheumatoid arthritis. We know of people with psoriatic arthritis, ankylosing spondylitis, who are playing elite professional sports. So it is doable. And certainly if they want to do that, I wouldn't stop them from doing it. I might suggest some ways to build into it slowly and go from there. The other slight consideration would be how their symptoms react. So I tend to say to people, I'm not too worried about the symptoms as long as they can tolerate them, as long as they're not lasting for longer than about 24 hours. Deterioration. Yeah. If you do something and you cry for 24 hours because it's so bad, probably that's not the best thing to do. It's not going to make your disease worse, but it's just not very nice. Or if it's lasting 3 or 4 days, it's just too angry. So we can tail that back a little bit. Yeah. But I'm not concerned about a bit of increased swelling.
Pretty comparable. Sorry.
Yeah, exactly.
Pretty comparable to any other disease as well. Like that's what I usually tell patients. Like the 24-hour rule. If it lasts longer, then you probably overdid it and you have a little flare up. So exactly. Pretty similar to what you just mentioned.
Exactly. Yeah. And I think it's about not being. I often say to physios, don't be scared of it, of making their symptoms a little bit worse. I think, if you take an Achilles tendon problem, high load, probably aggravate it with whatever you're doing. Don't seem to worry about it. Give someone with ankylosing spondylitis, aggravate it a little bit. Don't get scared of doing that. But it's, the patient's got to tolerate it. We don't want them being very upset or crying or it being really significant. And we don't want it lasting for an extended period of time. But, I use the same sort of rules. And that will be different for each individual as well. Some patients, they can go through a lot more than other patients or tolerate a lot more. It also depends what they've got to do. If you've got to go to work, you're just not going to be able to aggravate your symptoms the next day as much as if you don't have to do that. No. So it does change.
Okay, and if we look a little bit broader than exercise therapy, are there any factors, if I think of lifestyle factors, that can positively influence rheumatoid diseases?
Yeah, so we definitely don't want to be smoking. Smoking is pretty terrible for the rheumatology diseases. We want to be generally active, but also weight loss, especially abdominal fat, can make the diseases worse. So abdominal fat is actually active, immunologically active. It releases cytokines into the bloodstream, which raise the resting level of inflammation. So people with large waist circumferences tend to have worse disease, and they tend to have poorer outcomes with regards to cardiovascular disease as well, obviously, and also things like structural damage and medication use, those kinds of things. So if possible, that's a good way. General BMI doesn't tend to be such a good measure. It tends to be that waist circumference is the thing that's related more. There is some evidence around diet, but I think it's a lot more related to, again, the abdominal fat more than it is to the specific things you're eating. So it's more about having a general balanced diet rather than specifically eating things or not eating things. It's not like eat tomatoes and your rheumatoid arthritis will be worse. Don't eat tomatoes, it'll be better. That doesn't quite work. But it's about general healthy eating. They often say a Mediterranean diet. So, bit of meat, bit of fish, bit of veg, 3 meals a day. Make sure you're eating enough protein, that kind of thing, is the best way forwards. So keeping generally healthy, much like every other disease or every other healthcare problem, they're definitely helpful things.
Okay. I'm looking at my list of questions, and I think we covered quite a lot from screening to treatment at last. Is there anything that you would like to mention? And if that's not the case, I would say, where can people find you?
Yeah, I think the main thing for me is it depends on where you sit in the patient's pathway as to what, how detailed you need to be. Right. So if you are if you're going to be seeing the patient first, so they're not being seen by a doctor or other physios or whoever, then you've really got to have quite a broad knowledge base of how these different diseases present. And we've covered it quite shallow today, and as I mentioned, it does differ on each disease. So you'll see someone with rheumatoid arthritis looks very, very different to someone with ankylosing spondylitis. So it's about knowing that. If you're seeing people who have already been screened by doctors, etc., then you're going to more need to know about the treatment side of things, but you will need to know just what things look like in a bit less detail on an inflammatory pattern, so you can see whether they fit that pattern or not. And then again, if you're involved in diagnostics, you're going to need to know in a lot of detail what diagnostics you need to order, which bloods, which imaging for each disease, because it'll be wrong if you do the same screen for everybody. So I don't know what it's like in a lot of Europe, but in the UK, for example, a lot of the GP surgeries, they have a rheumatoid blood screen. So it's a little box, they tick it, and they get bloods, but it's the same regardless. It doesn't matter what disease you have, or you think it is, you get the same bloods. So it's just a bit useless because they're different. And some will be negative, some will be positive, depending on which disease it is. So that can be problematic. So it will be different depending on where you sit in that patient's pathway. That would be what I would say. And it's about getting the knowledge that you need for your part of that pathway, really. Right. And then where can you find me? Just type the Rheumatology Physio into pretty much anything, and I do come up at the top. I'm on Twitter. That's where I do most of it, is Twitter. But I do have a Facebook page, an Instagram, YouTube channel, and then podcasts and stuff. We're on the Physio Matters podcast and various bits and pieces like that. So yeah, we're all over social. Or I am all over social media.
All right. Thank you so much for your time and knowledge. It was a pleasure, Jack.
Yeah, thank you.
And also thanks a lot for listening to this episode. To access the transcript and additional resources, make sure to sign up for a free Physiotutors membership on physiotutors.com and benefit from more useful physio content. If you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with that said, this was Kai for Physiotutors, and I'll talk to you in the next episode. Bye.